This morning, we welcome Ron Bialek from the Public Health Foundation. His undergraduate degree is in political science, and he has a master's in public policy. He's been serving as the president and the CEO of the Public Health Foundation since 1997, and he's focused the efforts of the foundation on developing and implementing innovative strategies for improving the performance of public health agencies and systems to improve the health of communities. Initiatives include developing quality improvement tools and training for public health professionals, and creating the nation's most comprehensive public health learning network that goes by the acronym TRAIN, T-R-A-I-N. Again, let's welcome Ron Bialek.
Hey, Ron.
And
Good morning.
And I'd just like to add, Ron is my neighbor. He lives across the street.
But
I'm in Chestertown today, so after the meeting, I'd like Ron to go over and check the basement and see if there's any sewage backing up in the basement.
And if
let me know, Ron, will you?
Kevin, there was
he's allowed to help you.
Yeah, there was a stream coming down from up on the hill.
What color was it?
That's not even funny.
I don't know. It was orange. I don't understand. But
Yeah,
well,
about Agent Orange.
Thank you so much for inviting me here this morning. Although listening to the conversation, I'm not sure you want me to go on. But you can have a conversation amongst yourselves. But I'll try to make have an interesting discussion this morning. Let me go and share my screen.
Yeah.
Okay. Can you see that? Can you see the slides?
Yeah.
Okay.
And real quick, Ron, are you okay with us recording you?
Oh, no problem at all.
Awesome. Thank you.
Just as long as you don't use it against me. Okay, thank you. So the title of this is about us, the Public Health Foundation, and the work that we do to keep the public healthy. And Barry, thank you so much for briefing me on the chapter of the Rotary Club and your interests and the members. It's very helpful always to know who I may be speaking with in the morning. Just briefly, who we are a national nonprofit organization. We've been around now for just about 50 years. And our mission is to improve public health and population health practice to support healthier communities. And what we mean by that is that we work with organizations, we work with state, tribal, local, territorial health departments. Those are the governmental agencies, as well as other organizations, hospitals, health systems, in the work that they do with communities. So what we try to do is help them operate as efficiently and as effectively as possible, delivering quality services, whatever those services may be. So that's our focus as an organization. What I thought I would talk with you about this morning is a little bit about public health in general, what we do at the Public Health Foundation, challenges for public health moving forward, as well as actions to support public health. Sound okay?
Yes.
Right.
Sounds good.
Okay. So, first I'd love to hear what your thoughts are. What do you think? Or when you think of public health, what do you think it is? And I ask that question because my own background, I was in public policy, political science. That was my interest, economics, health. I had no idea what public health was. And it wasn't until my mentor in graduate school said, Ron, based on your interests, it sounds like public health is what you want to do. And my response to her was, well, I don't know. I don't think I want to be a nurse. I had no idea what public health was. So I just would love to hear your thoughts, what you think public health is, or what public health means to you.
Well, I think over in at Hopkins, on top of their public health building, they have the best definition: saving lives 1 million at a time.
That's perfect. Perfect.
This is Ron Sigelman. I think it's informing the public of good health practices and keeping the public informed about health issues.
Absolutely.
I think it is, this is Bob Sonamani. It's a translating what the science tells us in terms of protecting the life from the beginning to the end of life is basically what does the science is informing us that how we should be having a healthy lifestyle.
You know, these are,
Mental.
oh, sorry.
That's okay.
Was there another?
Mental health, society, mental health.
Mhm. And Kevin, you are muted if you're trying to say anything.
Isn't it enforcing laws or regulations to help maintain the public health, basically?
You know, everything that all of you said really is public health. I'm incredibly impressed with the knowledge that you have. And I think of, you know, I was looking at the work that you do with the Rotary, and, you know, you are a public health organization. You do work that impacts the population's health. You are everything from helping people become educated along the way to attain careers that can be lifelong careers that can benefit them and their communities, volunteer work, the work that you do around vaccinations. I mean, all of this is public health. So thank you for your public health work.
You know, my mother was an RN, and she got me one of the first vaccines for polio. And of course, Rotary's been working on polio ever since and has eradicated it. So that's one of our contributions to public health.
Absolutely. Thank you. Thank you. And you know, interestingly enough, if I think about everything that I heard this morning from you, Dr. Winslow, who was a bacteriologist, who actually started the first public health educational program at Yale University in 1915, his definition, the science and art of preventing disease, prolonging life, promoting health through organized efforts and informed choices of society, organizations, public and private communities, and individuals. I mean, that's basically what I heard this morning. It's the art, it's the science, it's the communication, it's trying to keep people healthy. And then if you look at the Institute of Medicine back in 1998, almost 80 years later, came out with a statement of, well, here's what we try to achieve, what we try to do, fulfill society's interest in assuring conditions in which people can be healthy. And the World Health Organization, and sorry, I didn't have the date for this one, public health aims to provide maximum benefit for the largest number of people. And again, I think I heard all of this in this morning's discussion. And I don't know if you can see to my left behind me, but that is my great-grandfather's painting. He was an artist. And that helps to remind me of the art part of public health. I was pleased to hear about your work and interest with the Native American community. The Native American community contributed to this public health description. This was just updated in 2020, actually, a national update effort to describe what we do in public health. And the Native American community looked at this, tribal health agencies, and said, you know, this looks a little bit like the medicine wheel. It reminds us of the medicine wheel. But really, sort of what we do in public health is we assess need, collect data, investigate problems, communicate, heard that, develop laws and policies, enforce those, work on enabling individuals to have access to healthcare. All of the things together are what we do. And in the middle here is working towards achieving equity. And you notice I didn't say anything about any specific diseases. I didn't say anything about diabetes, heart disease, cancer, etc. Because in public health, while we work on those specific diseases and work towards prevention, a lot of our focus is on the determinants of health. What can we do upstream? For instance, if you have an individual who's living in poverty, you have an individual who did not graduate high school, that individual is far more likely to have diabetes, to have heart disease, to have other health conditions in their lives. So it's important for us in public health to work upstream, trying to prevent these diseases from occurring and work on these social determinants of health, as well as the sciences of infection control, the science of exercise and prevention. All of this is our responsibility in public health. So let me speak a minute about what we've been up to this year at the Public Health Foundation. And I'll keep this relatively brief, but just to give you an idea of what we've been doing. You'll see in the upper left-hand corner an audit that we did of the Milwaukee City Childhood Lead Poisoning Prevention Program. This was a program in shambles. There was scandal. There was a Department of Justice investigation, and the City Council asked for an audit to be done, and the controller hired us to come in and audit their program. We put together a team of individuals who actually had worked in public health practice in governmental agencies working on the lead program. And we did an audit. We provided a variety of action items and suggestions for improvement, and have helped to guide the city a little bit in this way. Last week, they issued a press release that the City Council has allocated an additional $500 million and 25 positions to work on the lead problem in the city. Milwaukee has about 2,000 elevated blood lead level cases a year. And as you may know, or may not know, lead poisoning in childhood results in lifelong problems. 50% of the incarcerated individuals in Milwaukee who were incarcerated for gun violence, 50% had elevated blood lead levels as children.
Did you say 500 million or 50 million?
Sorry, I may have misspoken.
That sounds a lot of money, 500 million.
Yeah, I am incorrect. It's 500,000. Thank you for that correction.
Okay.
I was balancing my checkbook earlier this morning. I better go back and look. I appreciate that.
Because I follow the lead literature. I used to work for EPA, and I know what EPA is giving money for the lead problem around the country. So
yes, it remains a problem. This is a solvable problem. And so we were delighted to work with the city. We're delighted that they've taken action to make improvements. And most of the lead problem in Milwaukee and many cities is housing related, not water related, when it comes to childhood lead poisoning. So that's one of the proud areas that we have for 2020. A less exciting, but something that's very important nationally is in the bottom left-hand corner. There's something called the core competencies for public health professionals that we've helped to develop with a consensus group. This guides the education and training and continuing education of public health professionals. And this is going through an updating process. Last version was 2014, and we've now been awarded funds from the Centers for Disease Control and Prevention to move that forward. The other two items are COVID related and COVID and training related, and I'll talk a little bit more about those in a few minutes. So what I thought I would do is have a little story here, talking about something that we have done to give a better feel of the work that we do in the field. You can tell I am a public health person because at 8 in the morning, talking with a group of individuals, syphilis comes to mind. We talk about things that nobody else wants to talk about. And this story started with Orange County, Florida. It's where Disney World is. Orange County, Florida, where the health officer contacted us and said, you know, we're having a pretty significant problem. The orange line here for Orange County shows how syphilis was increasing pretty dramatically back in 2005. And the health officer said, I don't know what's going on. Can you guys come in? You do quality improvement. Can you come in and help us out? Help us figure out what the problem is. And so one of the most important things that we do with an organization is say, forget about the solutions that you have in mind Put them aside. Open your mind. Because what you're seeing may only be the tip of the iceberg. What may be affecting the problem may be under the water, and you're not seeing it. So put your solutions aside and let's go through a process. And we had the Orange County folks, different levels within the organization who were working on the syphilis issue, come together, map out processes, talk through and brainstorm what was going on. And ultimately, after only a 6-month period of time, they ended up seeing a dramatic decrease in syphilis cases using what they learned through the quality improvement process. So what do you all think happened? What do you think drove down that syphilis rate? What do you think drove it up? Any thoughts?
I think it's more
This is
awareness,
Ron
more
again.
education. Sorry, more education, more awareness. I think that's probably the key, is how the people are educated, not educated, but informed about the dangers of the syphilis.
Educating teenagers?
Thoughts? Other thoughts?
Advertisement.
Giving out free condoms.
Other thoughts?
Fear of HIV.
Right, especially if we look at the years here.
How about your tracing programs and effectiveness of that sort of situation?
How about the young people were gone? No more young people.
Yeah, right. You know, the comment about tracing, I mean, we hear a lot about contact tracing and case investigation today with COVID. That is often the case. And in fact, you know, some people thought it had to do with Mickey and Minnie, but no, they were behaving. They were just fine. So what was going on is gossip. Well, what do we mean by gossip? That health department and that program was not a fun place to work. People would come in the program, it was a toxic environment, a lot of office gossip going on. People would be trained. They would then ask to be transferred because it was such a toxic environment. Turnover was enormous. They couldn't keep people in the program. And so if you think about it, you train people on the processes, you train people on contact tracing, you train people on the program itself, and they leave. And you have a new cohort, and they leave, and a new one, and they leave. So the turnover contributed to them not following the processes and procedures and the policies that they had in place. And ultimately, the rate of syphilis went up. They dealt with the toxic environment, and ultimately, I'll go back to that, this is what occurred. The syphilis rate plummeted because they were doing the work they needed to be doing in the community, tracing, educating, and they drove down that syphilis rate. So when we say put aside the solutions so that we can really get to them, this is what we mean. The epidemiologists, you know, the scientists in the agency, they had all of their reasons for it. Turnover was not one. So again, they solved that turnover problem. Years later, turnover started to go up again. And guess what happened with the syphilis rate? But this time they caught it. This time they recognized what was going on and they were able to make an improvement. So this is the type of work that we do in the field as an organization. And you know, we see that this type of activity with quality improvement works tremendously. It taps into the minds and the creativity of the people within organizations. So we've seen in one health department, you know, 71% reduction increase in childhood exercising, another 100% increase in smoking cessation materials, another increase in immunization, and this one we saw the drop in syphilis. So when I had spoken with, when Barry was giving me guidance on talking with today, he said, you know, it'd be good if you talk a little bit about public health training, public health education. And when we saw Dr. Winslow's quote, and also comments made earlier, it's, you know, is public health a science or art? Well, it's really a combination. And so the type of training that we do in public health and we do at the Public Health Foundation, again, is around quality improvement, performance management. How do you engage communities? How do you work on community development? You know, earlier I mentioned about poverty and housing, education being critical to health. Well, community development financial institutions, community development corporations and others can have a dramatic impact on improving health. So how do we, the Public Health Foundation, help our community better work with those who do community development, policy, et cetera? And yes, we also do a lot of work with the sciences of public health. In my introduction, TRAIN was mentioned, and this, we're very proud of this innovation that we started now about 18 years ago. We have 2.7 million users worldwide. There are about 30,000 trainings within the system, some that may be only visible to certain professions, some that may be only visible to certain locations. We have 3,000 course providers who contribute to what's in TRAIN. These course providers come from institutions like Johns Hopkins, Centers for Disease Control Prevention, private organizations, and others. In total, we have more than 14 million course completions, and it's free. It's free to use. So any of you, if you'd like to, please take a tour. It's just train.org, a pretty easy URL to remember. We have users in every country except for 2. Is North Korea, and I can't remember the other one. Just to give you a picture of nationally, this is what it looks like. And I'm not trying to say that there are blue states and orange states. No, our orange states are what we call affiliates, and we give them rights to sort of work behind the scenes, if you will, within TRAIN, so they can access the data within their state. They can develop training plans, they can push out training and things of that nature. Centers for Disease Control, Veterans Health Administration, they're part of this community as well, Medical Reserve Corps, more recently the Food and Drug Administration, and others. So let's talk a moment about the COVID work we've been doing. I suspect you've heard a lot about COVID. You've had other speakers who've addressed COVID. And I want to give you a sense of what we've been doing in the response and sort of our niche. We look at a lot of what we do in the training realm. A lot of what we do is workforce development. And so what you see here is in the upper right-hand corner, we developed a series of live searches within our TRAIN learning network to make it easy to find COVID-related trainings. We also contacted many different providers of training to get their training into TRAIN. We have about 300 COVID-related trainings now in TRAIN, and more than 250,000 trainings have been taken through TRAIN on COVID-19. The bottom right-hand corner, we say we have this free customized service. What we do is for any state, tribal, local, territorial health department, any governmental health department, we will, at their request, create a tailored contact tracing curriculum for them. Now, why would you need it tailored? Well, there's certain national processes you use and guidance you use and science that you use, but there also are local and state laws, privacy laws, data systems, forms that need to be used. And so we will develop for them, usually takes about 2 days to give them a tailored curriculum that they can then push out to the contact tracers. They can track who's taking the training, what's been completed, and so they know that their contact tracers are trained appropriately for the work that they need to do. We also have been trying to get the message out. So that's the COVID-19 Frontline. That was a podcast that we did on COVID-19 with a group called Med Learning. And what we were asked to do is to speak with an audience of clinicians and to talk about effective prevention and management from the standpoint of equity and social determinants of health. So for instance, we've had physicians in the past say to us, I don't know what to do with my non-compliant patient. And that word non-compliant suggests there's a conscious effort of somebody to not do something. And what this podcast was about was, you know, somebody may not go and get tested because they don't have transportation to get tested for COVID. They may work the day shift and only be able to get in at night when everything is closed for testing. They may not want to get tested because they're an hourly worker, and if they aren't working and end up having to be quarantined, they're not going to be able to put food on the table for their family. They're not going to be able to keep a roof over the head of their family. So we try to get across what's behind some of the decisions that people make and the difficult decisions that they need to make, especially in this day and age with COVID-19, where people have lost their work, lost their employment, and have difficulty paying bills. So this is the type of work that we've been doing in response to COVID-19. Where are we heading as an organization? We are focusing on health equity issues. We are focusing on systemic issues that exist within communities and how we can contribute to greater equity. So there's equality, there's giving everybody the same thing, and then there's equity, which is giving people what they need to achieve, what they need to be successful, what they need to be healthy. One of the stumbling blocks we've seen over really the past 2 decades with the work that public health has done in communities around health equity is sustainability. And so our attention is focusing on how is it that we can work with communities to not only bring forward the science and the art, but also the long-term financing that's necessary to really make the systemic changes that we want to achieve. And yes, we remain in a coronavirus world. That's going to be with us for a bit. And so we are also turning attentions to the COVID-19 vaccines. I really should put an S here because there will likely be more than one vaccine. And we are doing similar work. We right now have been working with the Centers for Disease Control and Prevention to try to get some of the training that they have. And we're talking with folks at Johns Hopkins. We're talking with our colleagues in the field about what they need in terms of training. And we'll be looking to develop these live tailored searches for training, as well as providing training packages that can help organizations. With the vaccine, the Pfizer vaccine, that's likely to be the first one out of the gate, it has to be stored at 70 below zero. Shipped that way. And so there are all sorts of issues and training that's needed around the appropriate handling of the vaccine. How do you reconstitute the vaccine? How do you store the vaccine? Do we have the equipment within our public health agencies, our hospitals, our CVSs and others to properly store the vaccine? After you reconstitute it, you only have a certain amount of time where the vaccine can be given. You see, I have a picture of an abandoned car wash. That's one of the strategies that a number of communities are beginning to develop for giving the vaccine. If we think about it, think of Idaho. Think of January, rolling out the vaccine. Think about, okay, if we open a building and we have people come to the building to get vaccinated, you're gonna have clusters of individuals transmitting COVID. So how do we prevent that? Well, one strategy that's being looked at is using abandoned car washes where you drive in, you get your shot, and you move on. One of the downsides to that is with a new vaccine, it's good to be able to observe people for 15 minutes or so afterwards. If you have a drive-through vaccination clinic, how do you observe people for that 15 minutes afterwards to see if there's any reaction? So these are the types of things that we're now addressing and working on providing training, getting training out to our community. So what are some of the challenges for public health moving ahead? My good friend Rodney Dangerfield We just don't get no respect. You've probably seen it in the news about harassment of health officials, about health officials being scolded. One of my board members is the health official for Tulsa, Oklahoma. He was getting death threats when the president was due to come out there to have a rally. We were getting emails and phone calls from people lambasting us for having a board member who's this health officer in Tulsa. So respect is a problem. And we're not all that visible. Let's think about police and fire trucks, these red, fancy looking, noisy vehicles. Everybody sees them, ambulances, police cars. They're visible. Public health, we drive around in our Priuses. People think of us as the inspector, the naysayer. Don't smoke, don't do this, don't do that, or put on masks, wash your hands, eat healthy. And frankly, we don't always have the most interesting reading lists either. So let's think for a moment about public health, public safety. And let's pretend for a moment that this is our firehouse protecting Kensington, Chevy Chase, North Chevy Chase, Bethesda. This is our firehouse.
Beautiful.
Beautiful. It's decrepit. It has no fire trucks. It has one staff person who goes around and makes sure that nothing else falls apart. And now there's a fire. So the county council comes together and they say, okay, let's allocate some money for fire trucks. Oh, and let's get some people too. And let's train them. And they allocate the money for fire trucks and they train their people and they start working on improving the building. And they say, okay, now go put that fire out from 6 months ago. Of course, the house is burned down. It's too late. This is unfortunately where we are with public health, our public health agencies, our governmental public health programs in the country, is that a problem occurs and then we decide to invest to put the fire out. And in many ways, if we think about COVID, this is what we're faced with. And our response to it, we have the capability in public health to effectively respond. Unfortunately, we didn't necessarily have the resources, the respect, the people, the infrastructure to do what needed to be done as quickly as it needed to be done. And we still are faced with that today. So I always like to talk about actions that can be taken to support public health. I like to talk about things that all of us can do. Of course, I'm going to say social distancing, masks, washing hands, etc. In some places they don't have the luxury of washing hands either. Navajo Nation is what we do. We work with a number of tribes, and they don't all have running water. If you don't have running water, it's difficult to wash hands. Attack lead. Lead is a nationwide problem still. It is solvable, and it is a huge social justice problem. And this map shows lead risk areas within the state of Maryland. Just even helping people become aware that lead remains a problem. It's not as much the water that's contributing to the lifelong problems of children. It has more to do with lead that remains in housing, lead that remains in soil. Our health officer, Dr. Gales, send him a note, thank him. He's getting a lot of people attacking him. I'm sure he would appreciate hearing from folks saying, thank you for the work that you're doing. We appreciate you protecting them. And of course, I would say speak favorably about public health. Those who you come in contact with, your family, your friends, your neighbors, put in a good word for public health. That we're all doing the work that we need to be doing. And of course, as I mentioned earlier, you as an organization, you are a public health organization, and keep doing what you've been doing and doing it well. So that was it. And thank you so much for enabling me to talk with you this morning about this.
May I ask a quick question, Ron?
Yeah.
This is Barry. One of the bullets mentioned mental health as an aspect of the COVID-19 situation. And I believe one of our members had also mentioned that as a concern. Would you speak to that just a little bit?
It's used from really a couple of different vantage points. One is the health professionals. So we actually have some training on self-care, because it is grueling for those who are in the field working, 7 days a week, endless hours. One of my board members, the health official for a district in Idaho, I asked her after a meeting, I said, Carol, hope you have a nice weekend. And she said, yeah, I'm getting to take time off. She said, I've got 4 hours on Sunday. So that's one part of the behavioral health piece. The other is, people who are losing jobs, depression, suicide. Those are huge issues that we're facing. All of a sudden, opioids was no longer in the news. Opioids are remaining a problem and continue to grow as a problem. They're just not in the news. So there's increasing use of substances to help people cope.
Can I make a comment? With the public health, it seems to be more concentrated on the medical aspects and the global societal health itself, usually physical health. I mean, the mental health you're considering with things like the opioid epidemic, but with the COVID-19 pandemic that we have, I mean, the government, obviously listen to the medical science and to the doctors that are advising them about what to do from a strictly health science, from a societal health. And in all of your presentation really talked about societal health. Is it possible that perhaps one of the resistance that the agency gets for you and for your agency is that you're not really considering the entire picture, just the smaller focus of the physical health of the person, and making recommendations based on that, and not considering the effect that would have on the person's life, the quality of life, so to speak?
That's an excellent point, and that has been an issue. One of the, when I talked about the podcast, that was one of the aspects there is, empathy, and trying to understand a little bit further what's behind the decisions an individual may need to make, and the stresses that they have in their own personal lives that relate to them not necessarily being able to, again, stay home. Often behavioral health has been kept separate. Environmental health, they used to all be together. We go back again to Dr. Winslow in 1920. Behavioral health, environmental health, physical health, oral health, all of those were being considered together. Over time, they were pulled out as there was more categorical funding, and we're struggling to put it back together, quite frankly. So behavioral health often does get the short end.
I'm not just talking about behavioral health, but I'm talking about the effects of the public health recommendations.
Thank you.
They would have on your whole life when you're not considering the person's quality of life, that it may impact, and that person has his own definition of quality of life. It goes all to the whole thing about smoking and skydiving. These are things that are bad for your health, but they may contribute to that person's ability to live the life he wants to live.
Ron.
Yes,
I have 3 comments, okay? And I have been involved in the public health on a different angle, mostly environmental health. But the comment that I have, it has to do with the coordination across the federal agencies. The spokesman for the public health is the Surgeon General of the United States, with a very little amount of resources given to the public health. And there is no coordination about the message getting across to the population at large. What I see that, and I know some of the assistant surgeon generals in this country and over the years, so there is a very little, not much resources given to the Surgeon General to pass on the message. There is a different federal agencies, if you want to call it, including NIH, CDC, and several others, are disseminating the message not in a coordinated fashion. That's number 1 comment. The second, you mentioned about the one of the goals of it So I think what I didn't hear, the access to the public health care or healthcare in general is a fundamental problem in this country, as I see it, and many other countries for that matter. The second issue is the environmental justice issue. He's kind of touched upon it. It's a huge problem when it comes to the environmental health issues, the environmental justice issues. And the third has to do with the clinical research, which is done primarily in the majority of the population, but not in the diverse groups of population. So the application of that clinical research to the, all the members of the population is not well covered in terms of research, NIH research for that matter. And the last comment has to do with the lead issue, because I've been involved in the lead issues around the world. And the problem that we have there, we have reduced the lead level since 1978 to from 35 micrograms per deciliter, 100 ml of blood, to now 10 micrograms per deciliter. There is no threshold for lead. Lead is the most dangerous around the world in terms of contamination. We did reduce the level, the population exposure to lead in children. About close to 1 million children are still, mostly in the underprivileged communities, are still the problem. You know, as you mentioned, whether it's lead in pipes or whether it's, you know, different structures and so on. So lead is, as I said, is the push for the lead legislatively is to bring it back to 3 micrograms per deciliter is probably the goal that should be the Public Health Foundation goal, because there's no threshold for lead. It causes all kinds of neurological, reproductive, and to some extent, in animal studies at least, the cancer. So those are my comments. I'm sorry. I went on a little longer.
I appreciate that. And lead, yeah, lead is huge. Again, it's solvable.
I have a quick question. I'm so happy to hear that you're doing the COVID contact tracing training. I have a student who's employed in DC as a contact tracer. And I was asking, and he was informing us about his job. And it made me wonder if there is any assessment on how effective these people are, because it sounded just horrible and scary. He calls up, you ask the people, are you isolated? And he hears people all around and they say, yes, I'm isolated. And you're not allowed to query further. What's being done when the people contact trace, and what kind of follow through training? Or do you think it's a waste? Or
Well, gosh, oh boy.
It's a big one. I know it's a whole, but
well, so let's, first off, we have no national strategy. So if we go back to, you know, the comment about federal leadership, agency leadership, there's no national strategy on contact tracing.
Yep.
Then when you get to the state level, there's, in many instances, no state strategy. So we were working with a particular state, and the local health department was asking us to provide them with some training, one of these training packages, and we sent it to them, and then they said, oh, we're not allowed to use it because the state said, we just want to hire contact tracers, we don't want to train them. Yeah. So the strategies are all over the place with this. We do see it being effective.
You do.
Right? Where it is being done well, it's been effective. Now, there also are some newer trainings, actually, one that we recently put in to train from Johns Hopkins on evaluating and measuring so that you know if at the end of the day you're achieving what you intend to achieve. The problem that we see, and I'll go back to Milwaukee for a moment, Milwaukee has 1,600 backlog contact tracing cases.
Wow.
Well, what does that mean? So 3 weeks from now, if you contact people, it's right, there's no reason to do it. It's too late. Because the caseload has increased so dramatically, contact tracing is far less effective. When the caseload had declined and was declining, that was the time where contact tracing could have been enormously effective if we employed the strategies. So it's contact tracing, it's wearing the masks, it's the social distancing, it's the isolation. If you don't do all of that, the contact tracing isn't necessarily going to be effective. So now where you have the caseload much higher, it's more difficult to do in an effective way. And yeah, and back to the earlier comment about how this affects people's lives. It affects health, but also we have to think about, as came out so often in the presidential campaign, the lockdowns, right? We have to be sensitive to the impact of all of the decisions on the economy, on the individual health, and really put our heads together. How do we deal with all of that together? The problem is we are so divided that you have one side thinking about just the science, right? And one side thinking about just the economy. And that's never going to get us to where we need to be, in my opinion. So if we want contact tracing to be effective, you have to put the science, the economics, and the art together. So I would send your friend to train, or your student to train.
Absolutely.
For contact tracing.
Yeah. Well, on that note, we have reached the bottom of the hour.
Sorry for going over.
No,
Thank
it's
you.
totally fine. We always do. It just happens. Yeah, my dog has joined me.
Yeah, so cute.
Yeah, Ron, thank you so much. It was
Thank
very
you.
informative. And on that, unless anybody has anything else.
Thank you, Ron.
May
Thank
I
you for the
say
invitation.
something?
Thank
Yes,
you.
thank you, Ron. Very,
Very
very
informative.
informative. Yes.
Thank you.
Yep.